We've already addressed that these very extensive resections have got high risk, and the question would be whether or not we should be considering neoadjuvant therapy for some of these patients, and therefore I think it's very timely that we're going to address the issue of chemotherapy on the adjuvant and neoadjuvant basis. I should say our next speaker, John Primrose, is probably the most ideally suited person to discuss this. He's of my era, and throughout our joint period as colleagues, he's really been at the forefront of promoting clinical trials in the UK right across the HPV field. So I think he's the ideally suited to give us this presentation of adjuvant and neoadjuvant therapy for cholangiocarcinoma. Thank you very much indeed, John.
So thanks very much for that very kind introduction, Brian. We are of a similar vintage, and it's nice to see that we are both persisting in an active role, hopefully indefinitely. So as Brian says, I am a surgeon, but I have been occasionally mistaken for an oncologist. But I mean, how difficult can it be, really? On to the talk. So a couple of disclosures. Unfortunately, not very many. I mean, if it was something like Bridgewater, there'd be hundreds and hundreds of them. We love doing these operations, actually. It's a really nice operation, really nice dissection. I'm not sure we have the technical capacity of our Thai colleagues, but who see it a lot more. But it's a nice operation, but that's not the problem. The problem is relapse. So in summary of what I'm going to say, adjuvant treatment has really been transformed in the last decade and is pretty much standard of care. But neoadjuvant is experimental, and although there's promise in intrahepatic disease, it's certainly not established. So I think everybody's pretty much familiar with BILCAP, and so I won't go into the detail of this very much. It's a simple, two-armed, randomized trial, the sort that aren't very popular anymore because nobody will fund them, because I'll show you it takes ages and ages to do. And this is basically capecitabine versus observation. It was a success for a couple of reasons, although it took some time. Firstly, was good engagement across the UK, and partly that is because it coincided with a time when the clinical networks were introduced. And ultimately, we were getting about 80 patients a year into the study, and that's probably about as many as you could reasonably expect with a population like we have in the UK. And I think the results are well known. In the per protocol overall survival, you get about 14 months overall survival benefit with a two-sided comparison. Now, the controversy about the trial, which means that it's not available even in civilized countries like the Netherlands, is because the uncorrected intention to treat analysis just missed P's 0.05. So that's, but in most societies, capecitabine is standard of care now. Now, since BILCAP was published, the ASCOT trial came along, and in fact, the results are really very similar. This is S1 versus observation in Japan. 18 months overall survival benefit with a really good p-value, but really similar results. However, they did a one-sided comparison rather than two-sided, which isn't actually correct because S1 could, in theory, have been detrimental. And from the paper, we don't actually know what the ITT p-value would be using a two-sided comparison. What this teaches me is that if you're doing a trial and you've got a protocol, don't be too honest about it. So following on from this, GEM-CIS is obviously established standard of care in advanced biliary tract cancer, or at least was until recently. And the Arctica trial is following on from BILCAP. It's pan-European and indeed some global patients looking at capecitabine versus gem-cis. And this is the accrual. So 781 randomized patients. And I am pleased to announce for the first time today that the results of the trial are being submitted to ESMO. So if you come to Berlin in the autumn, you'll get the result of this trial. But I and the other principal investigators do not know the results. There's no point in trying to get it out of us. Certainly international trials are the way ahead if we're going to do these sort of two-arm trials. Actica did take a while, but rather less than BILCAP. So if we just look at the summary of all the trials that have been done, there's 2 negative trials, PRESTIGE 12 and BCAT from Japan. BILCAP and ASCOT were effectively successful trials showing benefit, and we await the result from Actica. Now, in the international guidelines, both ASCO and ESMO guidelines recommend an oral fluoropyrimidine as adjuvant. So this is established standard of care. So what did we learn from BILCAP? Well, if you do a randomized trial in a less common cancer, you need to take a very long view. And as an investigator, you need to have quite a long overall survival. I think Shahid earlier mentioned that we may need to alter how we do these trials, and the conventional large randomized trial for subsets of biliary tract cancer probably is not sustainable, and we do need to look at probably synthetic controls. But that's something we could discuss elsewhere. So where are the next trials in operable biliary tract cancer? Well, based on the TOPAZ trial, immunotherapy is now standard of care in advanced biliary tract cancer, albeit with actually quite a small benefit, but it's one that seems to be sustained and I note is commonly used now. So in the adjuvant space, this is the AZ adjuvant trial, which is now open. Why they would choose the name for the drug that is almost unpronounceable, I have no idea, and I'm not even going to try and pronounce it, but that's what it is. This is a trial of standard chemotherapy, and we'll discuss that in a moment, and plus or minus immunotherapy. And this is a trial design, a straightforward randomized two-arm trial. The interesting thing is the control arm. Now, I think you can justify capecitabine, you can justify S1. There are no data at all to suggest that gem-cis should be used as adjuvant, but it's used, I think, to support the USA participation, because that is commonly used. I presume it's used because you can charge more to give it than you can for capecitabine, but other than that, I can't think of a reason. However, it's possible that following the publication of Actica, this might be a reasonable option, but we will see. Now, moving to neoadjuvant treatment, there's no established neoadjuvant therapy, but there is potential. We're really, though, talking about intrahepatic cholangiocarcinoma. Perihilar is difficult because of the difficulty with biliary sepsis, obstruction, and cholangitis. And in distal cholangiocarcinoma, actually getting a diagnosis of cholangio rather than pancreatic cancer is really quite difficult preoperatively. And this sort of illustrates the situation in a hilar cholangiocarcinoma with multiple separated ducts. And sepsis is difficult to avoid, and it really is almost 100% if you drain it from below, which we think is an abhorrent practice and should never be done. So the potential, well, best upfront chemotherapy, probably GEM-CIS plus immunotherapy. Personalized targeted treatments, but for that, obviously, you do need to have tissue. And I want to just talk about probably quite a fanciful suggestion of hepatic artery infusion pump chemotherapy, because I think it has currently the most potential, if the most difficulty in setting it up. Now, this slide I got from the CCF meeting in Salt Lake City a few weeks ago, and these are some current trials that are being set up in the neoadjuvant space. And as you can see, they're basically early phase trials, but in general terms, they're looking at either immunotherapy combined with chemotherapy, or in this case, one trial looking at targeted therapy with penigatinib for FGFR rearrangements. Quite an ambitious trial to do, and we will see whether this proves to be feasible. But these are the sort of approaches that one might imagine one might take forward now. And this is a slide that I stole from John Bridgewater, and he'll probably actually show it later as well. The various targeted agents, and particularly the FGF fusion treatments, which really have quite a profound effect on intrahepatic cholangiocarcinomas, which bear those mutations. And this is an example of a patient that I share with John Bridgewater with a very large inoperable intrahepatic cholangiocarcinoma with an FGFR rearrangement, who had a dramatic response and an enduring response to penigatinib. Now, a bit about the pump. So hepatic artery perfusion has been around for a while and has been used in intrahepatic cholangiocarcinoma, particularly in the States. And this is basically the technique. You introduce surgically a pump, a catheter into the hepatic artery. A patient is treated with FUDR, which gives a very large dose in the liver. And the trials, mainly phase 2 that have been done, mainly from the USA and mainly from Memorial, show that the over-year survivals are extremely good in advanced intrahepatic cholangiocarcinoma compared to what you see in the combined analysis of the ABC advanced biliary tract cancer trials. And this Pump 2 trial is from the Netherlands, and Bas has to be congratulated for actually getting this trial done in Europe. And this shows the response, which was about 50% partial response rate, and one patient had a complete pathological response. Now, this is an advanced disease, not in the neoadjuvant space, but the same principles apply. And this is the survival curve compared to the ABC controls, which is really quite dramatic. So the data are convincing. The lack of introduction globally, it probably relates to most experience coming from one center in the USA. But in fact, the European trial shows that essentially the results are the same. But this is a very significant intervention. You have to insert the catheter through a surgical technique, not by an interventional one. Ideally, you use a robot to put the catheter into the hepatic artery. You need a higher level of surgical skill, and both the technique and the device is costly. And lastly, just to round it all off, FUDR is not actually even licensed now in Europe. So there's a bit we have to go to before we even contemplate this in the neoadjuvant setting. So in summary, I think we have to accept globally that adjuvant therapy is established with a fluoropyrimidine, and we do await with interest the results of the Actica trial. Immunotherapy is established in advanced disease and will probably move into the adjuvant and neoadjuvant space. But there are no data at the moment on targeted agents being used as adjuvant, but that may be feasible. Neoadjuvant, as I've said, is not established. Chemotherapy is probably infeasible in perihilar disease, doubtful in distal disease, but certainly in gallbladder cancer and intrahepatic disease, I think we'll see increasing number of trials appearing. We come again, though, to the problem of doing an RCT in a subgroup of a less common cancer, and I think different trial methodologies are going to be needed. And the pump is perhaps fanciful. Implementation is very difficult to imagine, but if you look at the results, they are really quite dramatic. And certainly in the neoadjuvant setting for borderline resectable disease, this would certainly be a way we could go. So targeted therapies and immunotherapy both have potential. Intrahepatic clearly is the most promising, but affordability is going to be a challenge in any healthcare systems, even the well-funded ones. So thank you very much for your attention. Thanks to AMF for inviting me, and hopefully we can have a discussion about these matters at the end of the session. Thank you.
Okay, thank you very much indeed, John. I didn't think I'd ever hear you say that randomised trials may not be effective in the future, so we'll come back to that one, I can assure you, at the end. And also pump therapy, which I thought we had explored about 20 years ago for unresectable CRC Mets. But things come round in cycles, don't they? So we'll revisit it.